Have a very exciting panel to kick off the rest of the session, and it's, I think, going to be a terrific follow-on to Senator Daschle's remarks, because this is the panel that's going to start with a discussion about policy. I am Marianne Udow-Phillips. I'm the director of the Center for Healthcare Research and Transformation here at the University of Michigan, and we are very focused on working to help translate research into policy. And there is truly no one at the university who has done it any better than Mark Fendrick and his team at VBID. This is a model for how we believe we ought to be thinking about health services research and its ability to affect policy in ways that make a difference. It is really exciting to reflect on what Dean Filbert said about the VBID project and the VBID focus. Because in this era of intense partisanship, VBID is truly a nonpartisan idea. It's one of those ideas that Senator Daschle talked about, that regardless of who you talk to on either side of the aisle, everyone can agree that this is a good idea. And as a result, we're seeing the implementation of VBID across the country, in the private sector. We're seeing it embodied in the Affordable Care Act and principles and health insurance exchanges developing around the country. We're seeing great models and gems of experimentation taking this concept and making it into an approach that consumers can resonate to and that providers can resonate to. So it cuts across just about all the sectors in healthcare in a way that is positive, that is innovative, and that is making a difference. Our panel this morning is going to talk about VBID in the context of policy. You heard from Senator Daschle that much of the work that gets done on health policy in this country is not done in Washington, D.C., although, of course, much of what happens there has a big influence on what happens in the rest of the country. But a lot of what occurs in health policy happens in the states. The states, as many have said, are truly that laboratory for change, along with the private sector and the innovations that we see there. Our panel this morning is going to talk about the policy-related issues, particularly from the state perspective. We're going to have, I think, very stimulating presentations. Each of the speakers is going to talk for about 15 minutes to present their perspectives, and then we should have, again, a good amount of time for questions and dialogue from the audience. So please think about your questions as you hear from the speakers, and we will have that period at the end to come up to the mics and ask questions. We're going to go from the far end in on the panel. I'm going to introduce all three speakers right now, and then they're just going to come up and follow each other in their remarks. In our discussion this morning, we're going to start with Stuart Guterman. Stuart is an economist and is the Vice President of Payment and System Reform at the Commonwealth Fund and Executive Director of the Fund's Commission on a High-Performance Health System. And he's going to start us off this morning setting the stage, talking broadly about the context that we're looking at with regard to system reform, with regard to VBID. Then we're going to hear from Alan Wheel. Alan is an attorney. He did happen to go to the Michigan of the East, and we're happy that we know he'll wear his maize and blue colors very proudly. He is Executive Director of the National Academy for State Health Policy and was previously Director of the Urban Institute's Assessing the New Federalism Project. And he is going to talk about the issues that the states are facing, and I think that Alan is all across the country and has just a wealth of information to share about what's happening across the country as well. And then we're going to focus a little more specifically on Michigan, and we're delighted to have Steve Hilfinger, who is the director of the Michigan Department of Licensing and Regulatory Affairs. Steve is also an attorney and comes from a long career in the private sector to state service over the past year, almost. And we're delighted to have Steve. He's going to talk specifically about what's happening here in Michigan with the health insurance exchange. He's got full agenda and some exciting things to share about that as well. So we're going to start with Stuart, and then we'll go from there.
Thank you, and it's a pleasure to be here. Before the panel started, Steve turned to me and said, so you've got to follow Senator Daschle. Congratulations. But I'm going to try and do that. And actually, Senator Daschle made a lot of the points that I'm going to touch on. What I'm going to do is provide some numbers to wrap around those points and kind of lead into the rest of the discussion. Okay, how does this work? Where do I point it?
Where is it going?
Ah, there we go. Did you change it? Point number one, as Senator Daschle pointed out, we do have the most expensive healthcare system in the world. The United States is without question best in the world at this one thing when it comes to healthcare. Okay. Okay. Some data from the Organization for Economic Cooperation and Development in the set of developed countries shows this phenomenon. The United States is the black line on top, and you can see that health spending in the United States is 50% higher than any other country in the world, both on a per capita basis and as a percentage of GDP. And actually, we are in 2011 at somewhere around 18% of GDP. And so it really raises questions about what the word sustainable really means. I worked years ago with Stuart Altman at Brandeis University, who worked for President Nixon on the wage and price control system that they had in place in the early 70s, and he used to relate how they used to wring their hands about what would happen if the U.S. hit 8% of GDP in health spending. Now we're well over twice that. And also another troubling thing is that the gap between the U.S. and other countries is growing. So this isn't a situation we have under control. This is clearly placing pressure on us. Now, there's been a lot of discussion in Washington, particularly about the role of health spending in the federal budget deficit, but this is a much broader problem than that. The projections of national health expenditures over the next 10 years kind of show this. The current projection, even after the Affordable Care Act, will take us from $2.6 trillion in 2010 to $4.6 trillion in 2020, which will get us almost to 20% of our GDP devoted to health care. And that raises another question about definitions. When we talk about scarce resources, I'm an economist, and we understand scarce resources to mean that there aren't enough resources available to do everything we could ever possibly want to do. But the word scarcity has a different meaning to most people, and it's important to take into account when you note that over the next 10 years, basically we're projected to spend $36 trillion on health care. A lot of people wouldn't consider that scarce resources. There are a lot of resources at play here. And the question is, how can we use those resources better to get the kind of healthcare system we want, and perhaps even spend less? The bottom line here, the black line, shows what would happen if healthcare spending grew at the same rate as our economy overall. And that would only take us from $2.6 trillion to $4.1 trillion over 10 years, which is still a 4.8% annual growth rate and still 60% higher than health spending than there is today. So when people talk about cuts, they usually talk about the differences between the green line here and the black line, or somewhere in between. So we have to, again, bear in mind what the definition of a cut is. We're talking about a cut to only perhaps 60% growth over the next 10 years, and I think a lot of industries in our economy would ask, where do I sign, if they could receive projections like that in terms of the amount of revenue that's going to be generated in their industry. So there are a lot of resources to think about how to allocate appropriately, and one of the problems is we just don't, in our system, allocate those resources appropriately. So as I said, health spending puts a lot of pressure on the federal budget. But it's a broader problem than that. In fact, the Congressional Budget Office did an analysis of projected spending on federal health programs and found that the leading factor in generating federal health spending increases was not the aging of the population, as is frequently pointed to because of Medicare and the increased number of retirees, but in fact, health care costs per person overall throughout the healthcare sector. So it's a problem that not only affects the federal government and the rest of us, but it also comes from the rest of us, and it won't. And that's one careful thing to carefully consider when we're talking about cutting health spending in the context of the federal budget deficit. Is that we need to make sure that we not only douse the flames, which are certainly nipping at our heels, if not starting to catch our pants on fire, but really put out the fire. That is, to address the pressures that are driving healthcare cost increases throughout our economy. And that's where, again, smarter spending comes into play. Here's the issue as it's seen from Washington. This is, again, an analysis by the Congressional Budget Office. It's a couple years old, but the picture is the same. What they did was they looked at federal spending, total federal spending, which is the dotted line, as a proportion of GDP over a long period of time. And then they looked at projections. What would happen if, from now on till the end of the century, the rest of the federal budget were frozen as a proportion of GDP and only health spending grew at the currently projected rate? And what you note is that in the United States, our federal budget overall has really varied in a narrow range between 16 and 21% over the last 40, 50, 60 years. And what CBO found was that even if nothing changed but health spending, that the federal budget would be pushed up to 33% of GDP by the end of the century, which is a number that makes Americans very uncomfortable in terms of the amount of our economy that we're willing to devote to the federal budget. So that's the pressure from the federal side, and of course it's driving a very large, unprecedentedly large federal deficit. And that's what the supercommittee is trying to address. Okay. But again, it's not just a matter of public programs. These are projections of the increase in costs over the next 10 years in Medicare spending per enrollee and in employer-sponsored private health insurance per enrollee. And you see that the increase in Medicare spending per enrollee is projected to be about 2.8% a year over the next 10 years, which is still sizable, still faster than GDP growth. But employer-sponsored private health insurance is projected to be much faster. So the same problems, and this is not a question of public versus private, it's a matter of pointing out that it's the healthcare system that needs to be addressed and not just public or just private. And the implications on American households, which are perhaps the most important thing, are striking. This graph, the left-hand graph here, shows the increase in insurance premiums over a period 2000 to 2009. You see that insurance premiums have more than doubled over that period of time, while workers' earnings have gone up at less than a third of that rate. So workers are finding that an increasing proportion of their incomes are being chewed up by insurance premiums, and then health benefits are keeping those wages from rising faster, as fast as they might as well. And the picture gets bleaker into the future. The average family premium as a percentage of median family income by 2020 is projected to reach about 25%. So that means that an increasing portion of families' resources are being devoted to protecting themselves from rising healthcare costs. So this makes the case that we need to do something about this level of spending. And about this clicker, okay, the question is, so what do we get for this money? Okay. The Commonwealth Fund recently released a scorecard on U.S. Health system performance, and we have done this now 3 times, in 2006, 2008, and then in October. And what we're finding is not a pretty picture. We do spend more than anybody else on healthcare, but when we compare the performance of our health system on 5 dimensions of health system performance, and we compare them to achievable benchmarks, this isn't perfection we're grading these scores against. We're finding actual examples of good performance along each of these dimensions. We find that the healthcare system brings home a score that we wouldn't be happy with if our kids brought them home from school. And in fact, that score has gone down relative to what's seen to be achievable over the period of time that we've been looking, which kind of indicates to us that, number one, as Senator Daschle said, although the United States healthcare system is capable of providing the best healthcare in the world, we don't do it reliably and consistently, and we don't appear to be getting what we're paying for in our healthcare system. And here are a couple of examples of how that plays out. One of the kind of flagship indicators is mortality amenable to healthcare, which is an index of basically the rate of deaths from a set of conditions that are thought to be addressable by good health system performance. And this has been a study that's been done over time. The first one was in the late 90s. And the U.S. was kind of in the low end of the pack among these 19 countries then. And then since then, in the latest data, 2006 to 2007, the U.S. has actually improved from 120 deaths per 100,000 to 96 deaths per 100,000 in terms of mortality amenable to health care. But other countries have improved more. So the U.S. has actually fallen to the bottom of this list relative to the performance of other countries, below the United Kingdom, Denmark, and with France at the other end of the distribution. And there's also a lot of variation in the United States, both in terms of cost and in terms of quality. And you can see from this graph that that resource use varies a lot more than quality, and that the relationship between resource use and outcomes doesn't seem to be there. In fact, in some indicators, it actually seems to be inverse. And again, going on the theme of access as one of the dimensions of a high-performing health system, you see here that receipt of recommended screening and preventive care for adults is not what it should be. In 2008, only 51% of adults age 18 received all the recommended screening and preventive care that they should have received. But even more troubling is, if you look at the bottom part of this graph, that access varies by income, and it varies by insurance status. And again, poor coordination of care is another aspect of our system. We do have a healthcare system that's largely still a set of cottage industries, and if you've ever anybody who's had interaction with the healthcare system, maybe not here at the University of Michigan, but in most of the country, it becomes clear that folks don't talk to each other, they don't work together to help coordinate care, and there's a lack of communication and a lack of attention paid to the treatment of the patient as a whole, rather than the provision of individual services, largely attributable to the fact that we have a predominantly fee-for-service payment system. Okay, let me skip through these. Okay, so what are the policy options? Is there okay, there are 3 sets of policies that are talked about in addressing the issue of our healthcare system. One is, and particularly controlling health spending, one is to cut eligibility and benefits. And there are multiple ways to do this. One is to, and I would generally describe subheadings under each of these bullets as the axe and the scalpel. One of the ways to cut eligibility and benefits is to raise requirements, to postpone eligibility age, to basically make it harder for people to qualify for programs and to qualify for coverage. Another is to restructure the way we do coverage to focus on care that's productive for people and to move away from care that's not as productive. And that is where value-based insurance design comes in. Another policy option that's talked about is trimming payment rates. And again, there's the axe and the scalpel. You can do across-the-board cuts, such as the Medicare Sustainable Growth Rate mechanism, which is still in place and threatens physicians with a 27% cut across the board, every service, every provider, every specialty for Medicare patients on January 1st if nothing's done. Or you can focus on the services that are overpriced, that are overprovided, and fix those payment rates. You can use purchasing leverage to get lower prices where prices are too high. You can try and rationalize the set of prices that are paid for services. If you look at the transparency issue was another issue that Senator Daschle mentioned. If you look at the prices paid for the same service at the same provider by different payers, you see a remarkable variation in what different payers pay. If you look at the prices paid by the same payer for the same service across different providers, you see a remarkable variation. You get the impression here that this is not a market that works well. And prices to an economist are signals about how how resources should be allocated. This is a signal, this is an indication that this market doesn't produce the appropriate signals, so we need to work on that as well. And you can ensure the right care. Again, value-based insurance design is a piece of that policy. You can blame everything on fraud and abuse, and people have estimated that 30% of healthcare is inappropriate, which is great. Except which 30%? Generally, people feel that the 30% that's inappropriate is the care you get. So we need to do a better job of identifying the care that really produces a benefit for the people who receive it, and move toward using more of that and less of the care that doesn't really produce any measurable benefit for the patient. So. Takeaway messages, there's really one big one: we need to spend smarter. And value-based insurance design is a big piece of that strategy. We have $36 trillion on the table that's going to be spent if we don't do anything. The question is, can we take $34 trillion and figure out how to spend it better to get the kind of health care that Americans need and want? The U.S. health system needs to improve its performance to move up from that score of 64%. We need to have better information, and we need to tie that information to financial incentives, to align those incentives across payers, across providers, across patients, and across all three groups, to have everybody work together. As Senator Daschle said, it's a very difficult job, but it can be done. And we really have no choice but to keep trying to do it. So, thanks.
This is a clicker improvement break. Well, while they're working on the clicker, I will just note that before I got my law degree and policy degree at the Michigan of the East, I got my bachelor's degree at that other fine, large public university in the United States on the West Coast whose colors are blue and gold, namely the University of California. And we call it blue and gold out there, not maize. But we don't know what maize is. Actually, anyway. So I am clickerless, so I will do vocal clicking, I guess. There are glottal languages that click, so maybe if I can click. So there we go. Someone's clicking for me. What I'm going to try to do in my time is bring the overall information that Stu gave you down to the level of states, talking about how quality and cost are critical issues at the state level, look at how states are responding to that pressure, bring this into the context of VBID, and then discuss a little bit how there are unique issues at the state level when you think about the possibility of value-based insurance design. I'm going to draw on data also from the Commonwealth Fund. They really are a wealth of information in this area. This is simply to remind you that when it comes to the kinds of preventive services, this slide shows adult preventive care, adult diabetics receiving appropriate services, vaccinations, dental care. There's tremendous state-by-state variation, as well as a question of the United States' overall performance relative to the world. And so if we're thinking about the potential for improvement and the gaps in performance in the country, we can observe those at the state level, and that observation can give us the impetus for the kind of quality improvement that VBID is designed to generate. And while states do not run the Medicare program, and these are Medicare data, these also array the states from low to high in terms of admissions for ambulatory care sensitive conditions, something we would think would be very responsive to appropriate incentives in delivery of care to keep people from going to the hospital when they don't have to. So clearly the quality issue presses down to the state level, and then the budget issues do as well. This is fun, I should Governors complain a lot about the role Medicaid plays in their budgets, and in fact, if you go back over about a 15-year period, this is a gradually upward sloping line. State spending on Medicaid as a share of their general fund has increased, but at a fairly low rate. But it is a constant pressure on state budgets. And what's hard about that prior slide is that it ends in 2010. If you look forward, you see what states confront, because the green line at the top is revenue, and states have experienced nominal declines in revenue. Even with the current recovery, they're still not back to where they were. And if you look at the bottom line, which is state spending, you'll see that coming out of 2010, there's significant increase as states lose their enhanced federal matching funds that they received as part of the stimulus law, and continued growth. So there's ongoing pressure, but there's also the anticipation of significantly increased pressure. So these were just to set the stage and basically say this is an issue that states need to grapple with, quality and cost. So what is the state response to that issue? Well, you are probably aware, if you follow state budget debates anywhere in the country, that the primary response in the Medicaid program is sort of a broad-based cuts, provider rate cuts and freezes, cutting benefits, taxes and assessments to fund the program, utilization controls and the like. These are sort of standard issue, across-the-board kinds of policies that don't do anything to enhance value, but they certainly can save you some money. And then the problem is, they have to be looking up when I do it. We also know from the Kaiser Family Foundation that the largest share of states ever in the last decade are cutting benefits and planning to reduce benefits. So this is sort of, again, it's what employers do, it's what everyone does when they face cost pressure. But states are also very active in payment reform, which is not just focused on Medicaid. There's now in the Affordable Care Act and predating the Affordable Care Act federal policy to not pay for so-called never events, things that shouldn't happen like wrong site surgery. States were doing this long before the federal government. Half the states are paying incentives for primary care practices to increase their capacity to become medical homes. A smaller number of states are working on true quality cost trade-offs with incentive payments. Pioneering bundled payments. In Minnesota, they call them baskets of care. which is an effort, again, to sort of find a grouping of services and pay a single fee to move away from the incentives of fee-for-service. And of course, there's a lot of discussion now about the federal regulations around accountable care organizations, and clearly that's being led through the Medicare program, but there are about a dozen states that, using different names, have various discussions underway to try to emulate the concepts of the ACO with provider-based delivery systems that are paid in part based on their achievement of certain goals, and to help, again, sort of facilitate the transition away from fee-for-service payments. So this is a very active area for states thinking about quality, thinking about costs. So as states move forward, the question is how can they think about value-based insurance design in the context of the world in which they operate? You need to remember, if you don't work in the Medicaid space, which most people don't, that the Medicaid population is not just moms and kids who look just like everyone else, and therefore what we learn about the commercial population can readily and automatically be applied to the Medicaid population. So for example, 70% of the people who are residents of nursing homes are covered by the Medicaid program. Almost half the people with HIV/AIDS are in the Medicaid program. 20% of people with severe disabilities are in Medicaid, and that means people with traumatic brain injury, developmental disabilities, severe and persistent mental illnesses. And awesome. All right. So what's important about this is that you can't just naturally translate the lessons from a commercial population where we may test out VBID principles into a population with much more complex needs. Indeed, measures of value are very different, and even measures of the effects of care. The comment this morning about home and community-based services, a lot of the services for the disabled are not about curing disease, they're about quality of life and preventing deterioration. And if we're going to take a broad perspective on value, we need to consider the population we're serving, and it's not just about chronic condition management. Of course, Medicaid is also critical, plays a critical role for low-income families and children, pays for 40% of the births in the country. So this is a program focused on low-income, high-need populations. The Kaiser Foundation projected who's going to be in the health insurance exchanges, which will cover 24 million people, and their projections on the left hand of these pie charts is that the overwhelming majority of the people in the exchange, even though subsidies go up to 400% of poverty, the overwhelming majority will be below 200% of poverty, and that brings in a lot of people who have different sets of needs than the current commercial population. So, for example, again drawing upon evidence from the Commonwealth Fund, if you focus on the left-hand panel of this slide, you see significant differences in receipt of recommended preventive care based on income. And if you're thinking about states and you're thinking about Medicaid and you're thinking about insurance exchanges, you're thinking about a low, moderate income population. And even in the best performing states, lower income people are significantly less likely to get the care that they need. So as you're applying these principles to the population of interest to the states, you need to keep in mind that the population of interest to states does face greater barriers even as they walk in the door than the population as a whole. And similarly, again, this is a simulation analysis to compare health status, and you see the anticipated enrollees in the insurance exchange far more likely to report fair or poor physical health or fair or poor mental health than the commercially insured population. So a reminder again of the different circumstances of the population and the risks associated with generalizing from a commercial population to the population states serve. Similarly, in this simulation where in the orange you see the anticipated enrollees in the exchange, much more akin to the uninsured when it comes to a lack of a usual source of care, not having had a checkup in the past couple of years, not having interacted with the medical system in the last year, than they are to people who have various forms of insurance coverage. So that's just a reminder of who it is we're talking about. So now let's put this into the policy context. These are what I would call speed bumps on the road to value-based insurance design. They're not barriers, but they are things that have to be kept in mind. So first of all, given the highly vulnerable and low-income nature of the Medicaid population, federal law already highly restricts the use of cost sharing because they don't want to create additional barriers to receipt of services. So if you want to use financial incentives, that tool of differential cost sharing is highly constricted within the Medicaid program, although there are exceptions, but they're small. Similarly, or differently, in the health insurance exchange, the dominant benefit packages are actually likely predicted to have very high deductibles and high levels of cost sharing. And so it's going to be actually quite hard to develop differentials when you're already dealing with potentially what could be $1,000 or $2,000 deductibles. How do you calibrate refinedly attuned financial incentives in an environment where overall people are looking at very high deductibles? And pair that with the fact that one doesn't want to talk about very much, that the federal government is going to pick up the tab for the credits, the tax credits that enrollees in the exchange are going to receive. And the definition of that tax credit is the gap between the cost of the plan and a share of the family's income. The state is not on the hook for the excess cost of those credits. And so as states are negotiating with plans and designing their exchanges, they don't have the same kind of price sensitivity at the outset that you might imagine a private payer would have. Meanwhile, we have what at this point is still very uncertain interaction across the essential benefit package, which has not yet been defined, state flexibility around that benefit package, and we don't know the degree to which that will occur, and the VBID principles. We know that there's reference in the Institute of Medicine's report on the topic, but the Secretary has not yet embraced that report, and we don't know, therefore, how states are going to be able to engage with VBID principles in their exchange design. Add to that the note that I've already emphasized, that you have highly vulnerable populations. And given that vulnerability, there are going to be many people who are skeptical about VBID, saying this is just a cover for cost shifting to a low-income population. You're saying it's low value, so we won't pay for it, but really what you're trying to do is reduce your costs. That, again, because much of our experience comes from a commercial population and you're trying to calibrate and lever people's decisions, you could actually exert excess leverage and tip people too far. And given the vulnerability of the population, these are people who are high-volume users. So what could seem like a modest financial incentive to a relatively healthy person could be an extremely large financial incentive to a low-income person with multiple conditions. And finally, I think there's a big concern among those who work in the Medicaid program that you don't want to penalize the recipients of the program for health system failures. Medicaid's a poor payer. There's limited access. So if you say, well, you get more if you go here rather than there, but over here won't take you because the payment rates are too low, you're actually penalizing a party that has no say in what the delivery system looks like. I would note, however, there are no policy barriers to applying these principles to state employees and retirees, and that's a big pool to work with. So at least there you don't have some of these constraints. So let me finish by asking, how can states be the locus of opportunity for value-based insurance design? And it seems to me the test here is not just can we expand the model and replicate the model in the Medicaid and exchange space, although that's certainly an important thing to do. But it's to look at other areas where we're underperforming. For example, in the center of this is state variability in the number of children who have a medical home. And so maybe value-based design isn't just about receipt of care, but it's site of care. Or having a usual source of care, the left panel. We do know that there are health benefits and cost benefits associated simply with choosing a primary care physician. And so maybe the thought is not just about point of service, but about delivery system and site of care. Similarly, we have tremendous variability in hospital admissions. There's a lot of focus in Medicare on readmission rates within 30 days. That's sort of seen as a Medicare issue. But these two middle panels talk about nursing home residents admitted to hospitals. And I noted earlier 70% of nursing home residents are covered by Medicaid. So maybe the thinking about value, again, can be not just a point of care, but how do we build better delivery systems and support those systems to reduce the kind of outcomes that we know we don't want to have that can then yield quality improvement and cost improvement. So I think part of the opportunity associated with the different populations that states pay attention to than the commercial population is to bring in some of these concepts and issues like nursing homes and highly complex patients, rather than just thinking of this as whether or not there's a higher copayment on your prescription drugs. This is the next phase. So I would just answer or pose this final question. Can states be the locus, and how can they be the locus of VBID opportunity? It seems to me the question is, can we think of value-based insurance design not on its own as a tool, but as a mechanism to align patient and provider incentives? After all, there's a huge amount of work, as I noted earlier, going on around trying to improve provider incentives. And if so, with so much of the payment reform discussion occurring at the state level, really the question is, can we integrate VBID principles on the patient side into these very robust discussions already going on about payment reforms on the provider side, so that there's a consistent message to provider and patient and the healthcare system as a whole, rather than one effort going on over here with providers and another very often politicized discussion going on with patients with respect to patients. So in closing, I would just note that in the health sector, where silos seem to be the problem that everyone notes and poor incentives the other one, the ultimate goal really should be to take value-based insurance design out of this silo of demand-side incentives for cost containment and integrate it into the supply-side imperative focused on broader delivery system reforms. While states confront important barriers to adoption of VBID, as I've noted with respect to the populations they serve, they need to move with care given the vulnerabilities of the populations for whom they're responsible. They're also an important locus, not only for explicating sort of the core VBID concepts, but also setting the stage for the next phase of VBID, which is this integration of demand-side and supply-side incentives for an improved healthcare system. Thank you.
I have clicker anxiety now from the last two speakers, so I'll try to work with this. I wanted to thank the University of Michigan and the VBID Center, Mark, Mary Ann, Dean Filbert, for this invitation today to come and speak. And I wanted to introduce Laura real briefly. Laura is the Department of Licensing and Regulatory Affairs. The governor created that department in a reorganization earlier this year with the small task of reinventing state government that was assigned to us. So that's what we're about, and certainly the initiative we're going to talk about is an example of that kind of reinvention. And the governor asked our department to take the lead in implementing his vision for the health insurance exchange in Michigan, which is My Health Marketplace. Chris Priest is here in the audience. Chris is our project manager for My Health Marketplace as part of our department, and is working with me and a team that I'll share with you later on this initiative. I am a U of M graduate, I'm happy to say, class of 1984. Thank you. I have a son who's a freshman here and hopefully a graduate of the class of 2015, 4 years. And as I shared with President Coleman, he shares my affinity for hard sciences. And so I don't know if he'll ever make it up to North Campus, but I hope he does, because this is a beautiful area of campus. As I said, I'm here to talk about the governor's vision for the health insurance exchange as recently embodied also in legislation in Michigan at SB 693 that I'll talk about. So the My Health Marketplace is an online clearinghouse that's been designed by Michiganders to meet the needs of the Michigan market. where we bring buyers and sellers of health insurance together with the help of agents, producers, and navigators to use technology to make the shopping experience for health insurance more consumer-friendly, like so many of our other shopping experiences. We think this will enhance market competition, and that's something that hasn't been talked about too much. Maybe we don't have the sensitivity to price that was mentioned, but what we think by creating a competitive marketplace, we'll start to develop more price competition, and that will help drive price sensitivity, but certainly not through price controls, but through a marketplace. We are a non-exclusive insurance portal. People can continue to buy insurance on and off exchange, and we hope we'll create something that has value to consumers, individuals and small businesses, but the market will really tell that, and if people decide that they don't see the value, they can certainly continue to procure their insurance in their historical ways. We do have pending legislation. Senator Marlowe led the effort, and he's been working on this very diligently, has been studying this issue. And last week, we had the Senate pass SB 693, the second substitute version of that, by a vote of 25 to 12. Thad Gormas is here, the Chief of Staff for Senator Marlowe, so I wanted to acknowledge him and thank the Senator and his staff for their effort in taking the lead on that. That was a big step. A lot of what I'm going to talk about, and I'm talking about today, is really embodied in that bill in terms of the concepts and the free market approach. Now, the dialogue continues in the House on that, and so that process continues with hearings. We're going to have a technology open house later in the week to sort of see some of the possibilities and some of the vendors and start to move ahead on that side. So My Health Marketplace is to be constructed as a nonprofit corporation. The Affordable Care Act gave two options. You could, as a nonprofit or as a governmental agency or quasi-governmental agency. The governor had a strong preference for more of a market-based approach. We think that setting it up as a nonprofit outside of government, it'll be more innovative, it'll be more nimble to make changes, and also we'll have the ability to be less politicized. I don't want to say apoliticized because this area is a very political area, but have the opportunity for more market-driven judgments and more effective and nimble procurement. So those were some of the driving factors. As the legislation is constituted, there'd be 7 voting members. 5 would be appointed by the governor, 2 by the Speaker of the House and by the Senate Majority Leader. And the OFER commissioner, which is the insurance commissioner in Michigan, would be a non-voting ex officio member. That would be, in our vision, the group that certifies health plans coming onto the exchange. So we wanted to make that person a non-voting member because of that fact. We'll have an executive director, and we anticipate having an advisory board composed of a broader group of stakeholders that will satisfy the requirements of the statute and also give the board that many more viewpoints. There are 2 pieces to the marketplace. I think most people are familiar with this. A shop, which is for small businesses and small groups. That would be 2 to 50 members until 2016. And then an individual marketplace. And the incentives for the shop marketplace in the first 2 years will be tax credits up to 50% of the employer contributions. In the individual marketplace, we'll have the subsidies that were discussed, and those have estimated to be $1.3 billion in Michigan in 2014. The other thing that we think is a benefit of the marketplace is it takes the 1.3 million uninsured Michiganders, gives them an opportunity through the marketplace to obtain insurance and reduce what we estimate to be a $1,000 per family tax on those of us that do have insurance in Michigan. So that's one of the perceived benefits of that. We did a study that was with the federal grant dollars, and the initial estimates were about 520,000 people would come on exchange through individuals, and then 500,000 additional Medicaid. So those are the existing estimates we have on those numbers. this slide is really what we've been all about the last couple months, is why do we have to act now? And you know, under the statute, if the states do not implement a health insurance exchange in their state, the federal exchange would be operated in those states. And some states have opted to do this. But I think the governor and a lot of the legislative members have really believed that creating our own exchange, that we can try to dictate the structure and give us an opportunity to put that in place, reduce some of the uncertainty that exists out there. The earlier we start, the better off we'll be to do that. So we are pushing for legislation still to be done in 2011, and that would facilitate us procuring IT systems, hiring staff, and doing all the kind of interconnects and other discussions we need to continue to have with the business community, the health plans, and other members of consumers. There is a ticking date that we're very cognizant of. We maybe should get a clock in our office too. But 13 months and 45 days from now, the federal government through HHS will certify whether or not the state is able to operate an exchange, whether they've demonstrated the capability and legal authority and things like that. So that is in the IT procurement, that really is a blink of an eye for us. So that is why we're counseling at every opportunity to move quickly and get this in place so that we are able to operate our state-level exchange. We're dealing with not just our systems, but as I said, those of providers, businesses, and many other interconnects. This is the timeline. I don't know if everybody can see that. On September 30, we applied for what was called a Level 1 establishment grant, and that was $9.8 million. We're hoping to hear very shortly from HHS if that's been awarded to Michigan. The next phase would be establishing legal authority in the state and doing some other things, and then Level 2 establishment grants would be more significant, and that's where most of the IT funding comes in. And again, as was mentioned, the federal government is footing the bill for that development, other than the 10% of the IT costs related to the Medicaid integration. And there are additional deadlines coming up for IT Level 2 funding, but we think that given the timeline we talked about, the time to move now on securing that funding is upon us. What happens if this is reversed by the Supreme Court or by Congress? That could happen. I mean, we certainly know that, and it's one of those uncertainties with this. But right now, the governor's approach is this is the law of the land, and we need to get Michigan in the best position to have a good outcome if this continues to be the law of the land as these deadlines come. So we also note that a portion of the law might be set aside or challenged. It's unclear whether the health and exchange piece would suffer a similar fate. So until my crystal ball gets better, we've been really counseling for having options. By starting now, we preserve more options than if we wait and just have a federal exchange imposed on us. And I would say that the governor, if this makes sense from a market perspective, he would like to do this whether or not there is a federal law that was the impetus for this. But again, in that case, it would really be free of federal restraints and mandates, and the market would really have to rise and fall on its own. And he thinks the value added to consumers would justify continuing with an exchange. We've been asked what's so bad about having a federal exchange. So there's three things that we would note, and well, four, I guess. If you want to hear more, we can talk afterwards. But number one would be a loss of state control over a big part of our insurance market. And right now, the Office of Financial Insurance Regulation certifies qualified health plans. That's the group that would look at accountable care organizations if they are to be formed in Michigan in terms of their regulatory compliance. So by letting the federal government run our exchange, we would be ceding that qualified health plan determination to the federal government. That's one negative. The second one is really a loss of state control over a significant part of our budget in terms of the Medicaid integration. It was mentioned that I wish we were at that 25% line that you had up there, because I think Michigan's share of our state budget, Medicaid, is about 31%. I think it's climbing to about a third. So that is a significant issue to us as a state, and we certainly would rather have the ability to influence that by running the exchange through the state rather than the federal government. We think it would have a negative effect on job providers by the inability to move now and try to structure it and control costs better. But we are not certain in a federal exchange whether agents would have any role, which is certainly important to many in Michigan. And we also are talking to many vendors who are potential vendors to the marketplace. And in a federal exchange, I think it would not have a very Michigan flavor to the vendor base. So the governor's talked a lot about economic gardening, and we think if the gardeners are in Michigan, there'll be a higher chance that some of the garden will be filled with Michigan companies. And then a one-size-fits-all approach is just something that we think is not desirable. Am I okay on time so far?
Just a couple.
Okay. So financing, we've been working off a $1 million planning grant, and I mentioned the level 1 grant. Then the principal financing up until the date that we would go live, and then for the first year would be through federal funding, with the exception that I mentioned on the 10% on the IT costs for the Medicaid integration. But after January 1, 2015, this has to be self-sustaining, and that would be done through assessments and user fees. And if you look at the legislation, there's provisions in there about that. Our view basically on those is let the market drive those and try to maintain flexibility. The user fees and assessments have to be reasonable, or the exchange will not succeed. So we think the market will govern that and help control that. I think everyone's familiar with the different metallic plans. As I mentioned, the qualified health plans would be certified by OFR under our vision and under the Senate's bill 693. So VBID plans and exchanges, how do they relate? Obviously, the characteristics of the exchange will impact the extent to which VBID plans are part of that. The two models, basically, with some hybrids in between, an active purchaser and a clearinghouse model. A clearinghouse model is our vision for the marketplace. Essentially, plans that meet the requirements of federal and state law and are certified by the OFR commissioner come onto the exchange. And we don't have an active purchaser model in our construct, which would be the exchange being more selective in terms of benefits and prescribing the structure of plans, and adding mandates to that. So that's an important thing to note in terms of thinking about how we would integrate VBID plans into the structure of the Michigan marketplace. Does value-based insurance design fit into it? We think it does. But that will be by creating options and hopefully having very good disclosure around quality and characteristics of plans. And I think it was said that we know more about baseball stars than our some of the providers. And there's very robust transparency included in the statute. Transparency that the exchange will have to have, the marketplace will have to have on the site, and also that the OFR commissioner would be asked to do. So we think a combination of creating opportunities for innovation in the marketplace, very good disclosure, good quality rating information that the board will develop, and having agents and producers and navigators help with the education. We think that'll be the best way to drive demand for VBID plans rather than mandating those. This is the team, hard to see. I mentioned Chris. Lisa Gigliotti was here last night at the dinner. She is our legal counselor, general counsel. Shelley Edgerton's involved in the legislative effort, and then Al Pohl is our budget lead. So this is a team. We're really incubators. We would like to form this and get it launched outside of government as soon as possible so that it can go about its business of getting ready for 2014. So thank you for the opportunity again, and I'll look forward to questions.
Thank you, and we do have a few minutes for questions, and while you're getting ready to come up, I would pick up just on a few points of the panel. The panel did exactly what we hoped, gave you from Stuart's perspective the very broad picture of the challenges that we face and some of the opportunities. From Alan's comments, what the states look at. And if you're interested to pick up on what Alan said in what it looks like in Michigan, we have copies here of the Cover Michigan Survey 2011 that we did. And in there you'll see a little bit about the kinds of things he talked about. For example, we noted that just about 1/3 of those who are uninsured in our state today have been diagnosed, have self-reported that they have been diagnosed with depression. And we know that most of those are going to go either into the health insurance exchange or into Medicaid. And so how do we, in the benefit constructs and how we deal with that population who really have some very significant health issues, how do we deal with those issues? And the comment that was made earlier about thinking about VBID from the perspective, the broader perspective, and the payment side perspective that links these things together and looks at community-based services that can often be much more important, and a public health perspective, I think, is a very important component of VBID that really gives great opportunities to the states. It doesn't just have to be structured in a very narrow perspective, but can really be conceived in that broader way of how do we add value for this population that will be coming into health reform. And then from the Michigan standpoint, I think we're really gratified and lucky to be in a state that is planning and moving as quickly as we are to implement the health insurance exchange. And as Steve said, the governor in his health remarks said, even if this wasn't in the Affordable Care Act, it is an approach that can make the marketplace work better, and that is what we need if we're really going to deal with the core issues that we have. And the way that VBID can work within that marketplace is really a testament to the work you all are doing, because we know many health plans in the state are already embodying VBID principles and will bring those principles forward in the qualified health plans that they hope to offer in the health insurance exchange. So many opportunities I think this panel has outlined, and would be happy to take questions from you if you're ready to come up to the mics, where they can comment on each other's comments as well. So, question? Okay.
Hi there, thanks. Yeah, question particularly for Mr. Hilfinger. We just talked about or heard about how VBID in Michigan will depend somewhat on transparency and on people caring about quality and knowing about it. Following on from Senator Daschle's comments earlier, is there also some effort to educate people about it? And I'm particularly interested at the moment whether you think small businesses know enough about exchanges, whether they will do by the time the exchange comes online, that kind of thing.
Well, there's certainly been, in the private sector, since the statute was adopted, a lot of attention to this and trying to get your arms around it, and having businesses, with consultants and other folks figure out what's the best approach for my business to adopt this. There's been so many uncertainties, though, and some of the regulations have been slow to come out that we still have probably the pile of questions is a little bit bigger than the pile of answers. But there certainly has been education effort, I would say that way. Through the marketplace, there will be a lot of education opportunities, both mandated and otherwise, to provide that kind of information. And there's a navigator term that's used in the statute. It's right now requires a lot more definition about what a navigator would and wouldn't do, but it's clear that they would be an important part of that educational effort in terms of helping people know what their options are, helping them find the exchange. And there's also a lot of requirements in some of the draft regulations to make it user-friendly, including to certain populations like the deaf and hard of hearing and blind, to make sure that there's accommodations in there. So this is a very complex area. It's going to be hard to make it simple, very hard, but I think there's going to be efforts, and for the marketplace to succeed, it needs to be mindful of that. It's got to be something that is easy to use, and otherwise it wouldn't succeed.
Yeah. And you might see, I think, some examples of that in what was done with Medicare Part D and the kind of navigator approaches that were used to really help seniors figure out a very complex system of where they get their drug benefits. So that might be a model to that. I don't know.
And also, I forgot, the agents will have a major role in helping people figure this out, like as they do now. I mean, this is it's still going to be a lot of small businesses will probably just say, please continue to help me, and if this is a viable option, use their agents.
Great. All right. How about if we go in the middle, and then we'll go to either side here.
Sure. Hello. So given that market-driven care tends to not always allocate resources to communities that have the greatest need, and as you were mentioning, I think VBID, one of the big challenges is ensuring that you aren't penalizing people who ultimately have no control over their access to care. What ideas or policy initiatives might you think would be helpful in not only boosting capacity within communities from the standpoint of infrastructure that do not currently have access to care, as well as improving access for people who may be low income but live in a community that currently does have the infrastructure in place?
Alan, and then Stuart, you might want to comment from the work you're doing too.
This is a huge issue, goes way beyond VBID, and there's work all around the country on trying to improve the allocation of resources, access to care. I think the short answer to your first point about markets is that under the Affordable Care Act, this is a highly subsidized market. This is not a market where people just buy what they have. They have eligible tax credit based on their income, and then they also have subsidies on cost sharing based on their income. And of course, in Medicaid, there are very tight limits on cost sharing. So one of the hopes of the model is that by dramatically reducing the burden of uncompensated care for those institutions that do exist in the communities that you describe, because they'll have a large share of the population they serve convert from uninsured to insured, the $1,000 tax that's often discussed about uncompensated care is not allocated equally because the burdens are not allocated equally. And so those institutions that are most strained also are poised to gain the most where the growth is the greatest. So this is the combination of market forces to allocate once you've done this major shift of resources. There are other individual provisions. There's the 2-year increase in payments for primary care services paid for fully out of the federal treasury in 2012 and 2013. There's the prospective payment system for community health centers. There's a high level of federal matching available to states that are building health homes under Section 2703 of the law. So this is a big issue. An area where states are starting to grapple. It's politically very fraught, has to do with scope of practice and how in a public institution like where we are, who are you training as the next generation workforce? So this requires a multidimensional approach. Part of it is pure finance, just get dollars to the right communities, but a lot of it is about actually targeted system improvement, targeted systems in those communities.
Yeah, I think that's a really important point to stress, that it's extremely important, crucial to align financial incentives with the way we want the system to work. But financial incentives aren't enough, and we need to recognize that, and we need to create an infrastructure so that what the behaviors and the outcomes that the financial aspect of the healthcare sector should be rewarding are in fact achievable by everyone. and accessible by everyone. And so and there are a number of provisions, as Alan began to mention, in the Affordable Care Act to try to do that. And the emphasis really needs to be placed on community resources to make a healthcare system not only high performing, but also accessible to all of its members.
Great. And could you identify yourself as well and your organization? We'll go you and then
Sure.
Jonathan.
Marcy Harris, University of Michigan. I just started to think School of Nursing. I just started in July. There's another HIE effort, the Health Information Exchange effort, and I've participated in some of the reviews of the HIE Health Insurance Exchange level grants that have been funded. I'm impressed that there's not a closer overlap between these two flavors of HIE, health insurance exchanges and health information exchanges. And I think that's critical infrastructure in the health information exchange component to enable health insurance exchanges. And I haven't heard that mentioned. Can you, your observations about that?
Yeah, it's a very good point. Go ahead. We'll go down the panel here, I think.
I think you're right. That definitely better integration needs to happen there. One of the members of our planning team across government is David Bean, who's the CIO for the state. And we've been working with Chris and David and his folks in terms of that, but I think you're right that there needs to be more attention to that. That was addressed in some of the early planning, but that's one of the reasons we want to move now, so we can start really rolling up our sleeves and thinking about the architecture. But in order to fund that and to move forward, we need a legal framework, and that's what we're trying to get in place.
I totally agree. I've been very concerned about this. My organization tries to help bring these two together, but it's hard. I mean, part of it is just the timing reality that the funding for the health information exchanges was through the ARA legislation, the high-tech provisions, and states were sort of gearing up and making progress, and then along comes the Affordable Care Act, and all these resources at the state level just swung from over at HIE to how do we deal with the 1,000+ pages and all of the different things we have to do. So part of it's just a state capacity issue. But I'll give a more positive end point, which is that I think this is really an evolution. As you heard from Steve, the emphasis at the state level right now on implementation of the ACA is dominated by developing infrastructure for plans and plan selection, for eligibility and enrollment systems. The Health Information Exchange is clinical data. It has an administrative data component, but certainly its potential is clinical. And we're just not having the clinical discussion yet. We're really building the insurance and the finance infrastructure. So my hope would be that although it'd be nice if we were doing more alignment now, and I wish we were, and in some places we are, it may just be that this is more sequential. And that we need a somewhat more evolved health information exchange, and we need a better solidified insurance infrastructure, at which point then the merger of the clinical and administrative data would have more meaning.
Do you want to comment too, or you're good? Good. All right, we have time for one more, and we're going to go to Jonathan over here. And so I think you're all here for lunch, or some of you are here for lunch, so hopefully you'll have your chance to engage the panel at that point. Go ahead.
Hi, my name is Jonathan Moore. I'm a Master of Public Policy student here at the Ford School, and thank you for your insightful comments. My question was sort of related to a comment that was made earlier. It seems as though the federal government is probably going to be on the hook for a lot here. And it seems to me that the risk profile of the population in these exchanges could be disproportionately unhealthy. I'm wondering if modelers have looked at this issue, what they've said, what states can do, what the state is concerned about. What are our options here?
Okay. Yes, modelers have looked at it a lot. There's a lot we don't know. We don't know the effect. We don't know if there will be an individual mandate. The Supreme Court will tell us that. We don't know how. We know it's not very strong, so we don't know how that'll affect the profile. One of the things that people often forget is that without the mandate, although the risk profile is worse, the cost of the program is less because you're actually insuring fewer people. So it's less effective, but it's not more expensive. There are very complex short-term and long-term risk adjustment mechanisms designed in the law, a lot of technical work going on at HHS to try to figure out how to spread the risk across plans and within and outside the exchange. There are rating provisions that prevent or are designed to prevent barriers to risk selection between the exchange and outside the exchange. There's a big role for state insurance regulation in terms of marketing practices, rating practices, and the ability to do monitoring of plan performance. So I can assure you that there are a lot of really nervous people who are really also very smart, who are paying attention to this issue. I think when I talk to the insurance sector, they describe this as the biggest risk to the success. So I don't think you're alone. You can take some comfort in that, but it is going to take a while for us to figure out how effective those various tools are. And a lot of what we are not going to know until we're enrolling people is what the actual risk profile of the enrollees is. We can do a lot of modeling, but it's very, very hard to know how it's going to play out. Enrollment will ramp up much more slowly than people think. We know that from the CHIP program. No matter how low cost, no matter how much we all think, oh my God, all these uninsured people are going to be there January 1st, 2014. It's going to take years for people, the issue about small business marketing, it's going to take years for people to build trust. So this is going to be a very dynamic issue for a long time. Thanks.
All right. On the nervous note, we are closing this panel, and thank you all for your participation. Could we thank the panel again for their excellent remarks?